Welcome to our program for AERD Awareness Day 2021. We're looking at Aspirin Exacerbated Respiratory Disease, AERD, and we're looking at your questions and answers from Dr. Tanya Laidlaw, who comes to us tonight from Boston. Dr. Laidlaw has volunteered her time this evening, and we're just so grateful that you're here with us. So Dr. Laidlaw, please introduce yourself, and we look forward to hearing from you and having you answer a multitude of questions about AERD.
Excellent. Thank you so much for inviting me and for having me, for being interested enough in this disease to learn more about it, to try to help our patients. In part, this is because of AERD Awareness Day, which is coming up this weekend. And so we have our AERD Awareness Day swag on as much as possible, trying to increase awareness around the country and around the world for this disease. So my name is Tanya Laidlaw. I am a specialist in allergy and immunology, but I'm sort of hyper specialized in AERD. So the vast majority of the patients who I see have AERD, or we're trying to decide if they do or not. And about 80% of my life actually is dedicated to research, and almost all of that is dedicated to research around AERD, both clinical research, trying to find what the causes are, better treatments, and also the lab bench, trying to really understand the immunology and the inflammation that causes this disease. So today's goal really is to go through what the disease is very basically. So this is going to be sort of a high level thoughts on AERD, make sure that we all kind of understand the basics of what we're talking about. Sally's then going to talk a bit about some of the resources available that are available online for folks. And then we're going to launch into a whole long list of questions, because really the goal here is to try to answer as many patient questions as possible. We have a whole set of questions that have already been sent in by patients. I'm going to do my best to answer them. I won't necessarily have answers to all of them, but I'm going to work through them as best as I can. And then ideally we'll have time actually for answering live questions from folks in the audience today as well. So, what is AERD? It was originally, or often early, called Samter's triad, after someone named Dr. Max Samter, who studied the disease in the 1960s. And we now refer to it as Aspirin Exacerbated Respiratory Disease, with the goal there being to show that it is a respiratory disease that is exacerbated by aspirin. So the respiratory disease actually will still exist as a chronic inflammatory disease, even if patients don't ever take aspirin. And the truth is that the third component of this here on the list here is the sensitivity to aspirin or any nonsteroidal anti-inflammatory drug, so any NSAID. So a proper term for the disease is also NSAID, exacerbated respiratory disease. In the United States, that usually means aspirin, ibuprofen, and naproxen are the three most common things that we see over the counter that end up causing these reactions. So the three big clinical components of the disease are asthma, and that asthma is usually severe, but not always, and sinus disease with recurrent nasal polyps, and then these weird sensitivities to aspirin and to NSAIDs that usually involve the respiratory tract. I will say that about 95% of patients with AERD have asthma, so about 5% don't. So we every now and then we'll find someone who just really doesn't have any asthma, but everything else about them is just like an AERD patient. And about 50% of all patients with AERD have severe asthma, but we see more mild and moderate asthma as well. The two really most classic things about it are these very recurrent, very obstructive nasal polyps. They obstruct airflow through the nose, so a lot of our patients can't breathe through their nose at all. And they almost universally cause at least either complete anosmia, so total lack of smell, or hyposmia, lowered sense of smell. And then these sensitivities to aspirin and NSAIDs. So AERD tends to develop relatively suddenly, although there can be a more gradual onset as well. And the classic age is sometime in the 20s and 30s and 40s. I have had patients in their 60s and 70s who developed it for the first time, but it's much more rare to be in your 70s when you develop it. I've also had patients in their early teens, 12, 13, 14, also much more rare, but possible. There is no clearly known and agreed upon trigger for the disease. It's not an obvious infection that we understand. It's not an obvious, what we call an environmental insult that you inhaled and caused it. We are still working hard to figure out what that initial inciting trigger, we say, caused the disease. So around 30% of all adults in the US who have both asthma and nasal polyps have AERD. So if you have asthma and nasal polyps, my general recommendation is that we should make sure that you do or do not have AERD. That number comes out to be around 1 to 1.5 million patients in the United States. So this does not qualify as a rare disease in the United States at all. It is much more common than I think most physicians realize. So, people with AERD classically have asthma, nasal congestion, and recurrent polyps. The nasal congestion often sounds a bit like allergies, and I'm putting allergies in sort of fake air quotes, because actually this is not always worsened by environmental allergies, and a lot of our AERD patients don't have true environmental allergies at all. And unfortunately, sort of using the traditional standard of care for other patients with asthma and sinus disease is not always enough for patients in AERD. They tend to be at more of the severe end of the spectrum. So the symptoms that we see really commonly, nasal congestion is almost universal, that our patients will at some point in their life notice severe nasal congestion. Itchy, watery, and red eyes can be there at baseline, but are often much more common actually as part of the allergic reaction to either aspirin or NSAIDs. Coughing, wheezing, chest tightness are classic asthma symptoms in general. They tend to worsen again with those reactions to aspirin and NSAIDs. Headache or sinus pressure is very common depending on how big and how bad the polyps are, right? So keep in mind that when I look in your nose, I see polyps only here in the lower part of the nose, but in fact, that suggests there are polyps in all of the sinuses, behind the cheeks, behind the eyes, and in the forehead. And those nasal polyps can really cause a lot of pressure and pain within the sinuses. In general, patients don't have nausea or abdominal pain as part of the chronic disease, but it certainly can come out as part of those reactions to aspirin. And again, hives and rash is much less common as a chronic symptom, but can happen as a component of the aspirin and NSAID reactions. And we have noticed, although I don't refer to them as hives per se, a lot of patients will think they're hive-like. A classic itchy rash, we see about 10 or 15% of our patients that's very itchy in the hands and the feet and the ankles. And that can sort of come out during reactions or come out in general when you're not doing well. And we haven't quite figured out what causes it, but it's very classic for AERD. We also discovered a few years back that around 70 or 80% of patients with AERD notice a respiratory reaction when they drink alcohol. And it does not mean intoxication. It usually will happen within the first glass of alcohol. And most patients will say they notice increased congestion, and some will actually have a full-on asthma exacerbation as part of the alcohol consumption as well. So it's something we need to warn patients about. So one of the things that we're running into, one of the points of the AERD Awareness Day, is that the diagnosis is incredibly key. If we do not have that diagnosis correct and as early as possible once the symptoms begin, we can't then appropriately pathway our patients to the right sets of medications and treatments for them. So we are still struggling to make sure that patients with the symptoms are seen in a timely manner and are appropriately diagnosed by specialists who know how to care for the disease. We found at our AERD center at the Brigham, so at the Brigham and Women's Hospital in Boston, part of Harvard Medical School, we have it's probably the largest AERD center in the world. We follow about 600 patients in our own clinic, and we have another 1,000 to 1,500 patients nationally with a registry of about 1,600 patients. Even in Boston, when this is like the biggest area for the AERD center in the world, our average time from patient symptom to true diagnosis can be up to 10 years. So it's somewhere between 5 and 10 years, which means that they are suffering for years without getting the proper diagnosis. And we, the medical field, needs to do a better job at diagnosing. So part of this, both in terms of helping patients get appropriately diagnosed, but also, frankly, teaching the medical field about the disease and providing opportunities for patients who know their diagnosis to get a better handle on it. The Allergy and Asthma Network has created a whole set of resources, and I'm going to turn it over to Sally now to talk a bit about what is available.
Well, thank you so much. As Director of Education, I work hard to make sure that we have a lot of great resources for you. And one thing we do have, and our website is allergyasthmanetwork.org. But we do have an AERD webpage. It's under Health A to Z. And you can see the questions here that we try to answer on the webpage. I'm not going to read through the list, but if you want to just take a quick look, basically we have so many patient questions that I just want to run through these resources rather quickly. And on the next page, you're going to see some downloadable free resources. And one thing is we have a guide. It's called our AERD, a practical guide for patients and providers. And that's kind of an AERD 101 that you can download. And it's a great tool for you to use. And then we've got an infographic that says, what is AERD? And we have an AERD fact sheet as well. We also have some short patient videos, and we have AERD 101, Diagnosing AERD, and Living with AERD. So those are in our Patient Learning Pathways series. Feel free to take a look. I don't think any of them are over 8 minutes, so it's a quick listen, but it has great information. Oh, no, that's great. If you want to go to the next slide, that's wonderful. We have 4 new infographics and posters for AERD Awareness Day 2021. And if you go to our website, you'll see the full graphic. There's scrollable graphics, which we thought was really kind of a fun way to do this. One of them is on aspirin desensitization in AERD. One's on alcohol intolerance. And then there's 2 others. One of them's for talking to your family, and one's for talking to coworkers about AERD. So you can help people understand what your experience with these issues are. And since we have so many questions tonight, it's time to get to some of them. So Dr. Laidlaw, we appreciate your answers.
All right, we'll see what we can do to try to provide as much information as we can and to help make sure that we can bust any myths if there are any out there and help answer some questions. So these are some of the questions that have come in already that we've put into here, and I'm going to just walk through them. I've seen them briefly, but I'm going to answer these as though it was a patient asking me this question in my clinic. In the current pandemic, we have had a lot of questions related to COVID-19 and have done the best that we can to gather as much information and do research around the country to understand the influence of COVID-19 on our patients. So one question we get all the time is, are we at greater risk from COVID due to having AERD or any AERD medications? So we have learned that for the most part, asthma and sinus disease of the kind that exists in AERD patients is actually either not at all a risk or an increased risk, or if it is, it's a very tiny risk. Now, it turns out that actually severe asthma is often a risk factor for more severe viral-induced respiratory disease. So many of us were fearfully expecting this to be a bigger risk factor than it was, but the data has really shown actually that the asthma and AERD that our patients have does not seem to increase the risk of severe COVID infection. And as far as we know right now, none of the medications that our AERD patients usually take seem to be truly immunosuppressive in a way that would increase the risk of COVID. In terms of the COVID vaccinations, I will just start off by saying I strongly recommend all patients in the country, certainly patients with any respiratory disease, to get a full set of COVID vaccinations as appropriate. The only thing to think about there is we do have a small subset of patients whose disease is so severe that they're actually on relatively high doses of oral steroids, often prednisone, in order to control their asthma. There's some suggestion historically, not specific to COVID vaccination, but historically that some of the vaccine responses are a little bit lower if you're on kind of higher doses of prednisone. So this might be a time to either get a 3rd dose and consider yourself to be in the immunosuppressed kind of category for that the CDC is now talking about, or to see if there's an opportunity, even for just a couple of weeks, to come down to lower doses of prednisone to make sure that you can have the appropriate, good immune response to those vaccines. So we have had maybe 600 or 700 patients that I know of well who have gotten their COVID vaccines. We've had all 3 in the United States. We've had patients get Pfizer, Moderna, and the Johnson & Johnson. We've had 0 of them cause an AERD reaction, absolutely none at all. So I think from that sense, I feel very safe recommending it for sure. In terms of the booster shot, this is going to be a moving target, right? So as of this morning, we already have new information. My answer is going to be slightly different than it was last week. So please, as this goes into recording, if someone's watching this in the future, what I'm telling you right now may not actually be the latest information if this comes out in a few weeks or in a few months. As of today, simply having AERD, but otherwise not having any other risk factors for age or immunosuppression, we are not recommending that you put yourself in the quote unquote immunosuppressed category and get a 3rd dose in the series of the regular vaccinations. However, as of today, the CDC does recommend that if you've gotten 2 doses of the Pfizer vaccine, that 6 months after your 2nd dose, you're eligible for a 3rd vaccine called a booster shot. If you fall into any number of categories that are on the CDC website, including being over 65 or at any increased risk of infection, depending on your workplace environment. So there are going to be a set of patients, probably even on this call today, who do very much qualify and probably should get a 3rd booster shot. So in terms of awareness, patients have heard there are likely somewhere that number 1 to 2 million patients in the US with AERD. Do I think that most of them are undiagnosed? Yeah, I do, actually, and it frustrates the heck out of me. There isn't a good way to prove that someone has a disease if no one knows they have a disease. So that's a hard thing to really get a grasp on. How many patients out there have this and don't know it? It's just very hard to get that denominator out there. When we did a careful look in our computer records for our medical records within the Brigham Women's and Mass General Harvard hospitals, again, we have multiple AERD experts in that area. So I would think that we're better than average at diagnosing. A couple of years back, we found that somewhere around 20 to 30% of patients, it was unclear what the diagnosis was they had. But if we drill down really carefully into clearly had asthma listed, clearly had nasal polyps listed, and also in their chart had a listing of some kind of allergy or contraindication to aspirin NSAIDs because they had had a respiratory reaction. So pretty clearly, like 90 to 95% of those patients are truly going to have AERD. Somewhere around 15 to 20% of them, there was no mention anywhere in their chart by any doctor who had ever seen them, anything that sounded like they knew they had AERD. The word AERD wasn't mentioned. The word aspirin-sensitive asthma wasn't mentioned. The word Samter's triad wasn't mentioned. So if in our system, 15% of the patients who even classically present with all of those 3 symptoms are not properly diagnosed, my concern is that there is a much higher percentage across the country who are not diagnosed. So why aren't more doctors aware of the disease, and how can this change? I don't know the answer to that. I can only give the experiences that I had, and I have to say, I went through 4 years of intense medical school and 3 years of intense residency. I had never once heard of the disease in the 7 years of training that I had. It was not until the first week that I joined the Brigham Women's Hospital for my fellowship training, my specialty training in allergy and immunology, where I even heard of this disease, and it was discussed for the first time that first week. So it took me 7 years of training before I even heard of the disease. I don't know how we haven't quite peeled down into the medical training in the earlier years. I am hearing more that it is now introduced in medical schools, in nursing schools, and PA programs, physician assistant programs. Many of our research coordinators or our technicians actually then go on to med school and will text me back and say, oh, they just brought up AERD in my class and I was the only person who had heard of it. So I do think that we're getting better, but clearly have a long way to go. So the next question about billing codes, this is one I'm just going to be honest with you and say, when will there be a diagnosis in medical billing codes for AERD instead of just having the separate symptoms listed? This is probably referring to something called an ICD-9 or ICD-10 code. I don't know. I'm just going to leave that there. I don't know when. We have tried in our division to contact the national teams that create these billing codes and have gotten nowhere. It is still not clear to me who's in charge of that or how I can get into their face to try to increase this. But at the moment, I do not yet have a good answer for when we're going to get that. So patients, how can patients, or how can we as their physicians, get other physicians, doctors, dentists, specialists, to take AERD seriously when considering pain relief options? This is a good question, and I will occasionally warn my younger patients about this. And I think what this question is probably referring to is that if you are not desensitized to aspirin, or you really can't safely take any NSAIDs at all of any dose, no aspirin, no ibuprofen, so no Motrin or Advil, no naproxen, so no Aleve. And the other injectable medication that we have in the hospital is Toradol or Ketorolac, also all in the NSAID category, all great anti-inflammatory pain medications, all will cause a reaction to AERD, which means that for the most part, your pain medication options are acetaminophen or Tylenol, which is actually not an anti-inflammatory and not a particularly strong pain medication, or narcotics with very little in between. And there is a real concern, and depending on where you are in the country and sort of the socioeconomic status of that area and of that emergency room, I absolutely have had patients walk into the emergency room with severe pain and say, I can't take any ibuprofen or any aspirin, I can only take narcotics, and be turned away because they were listed as being drug seeking because they were asking for narcotics. So I warn my patients now about that. It's something that I write in the chart. So anyone in our medical system who's looking into our patients, like that's a very clear part in there. And if it's something that patients feel like is a bigger problem than I'm even aware of, it's something that we probably can try to create a handout kind of infographic for that would teach other physicians about it, because I think, when you need appropriate pain care, it's just tragic that patients would ever be turned away from that for a reason, for their own health. So this is a frustrating one for sure. Let's see. So is there any research being done to develop an easier test for AERD, like a blood test? So the answer very shortly is yes. The longer answer is, I've been working on this for 15 years and I'm not there yet. The problem is that we do not yet really understand what distinguishes AERD patients from non-AERD patients. So if you're a patient with asthma and recurrent nasal polyps and have no reaction whatsoever to NSAIDs or aspirin, you don't have AERD. But if you're the same patient and you do have reactions to NSAIDs and aspirin, you do have AERD. That is the distinguishing factor. We have yet to understand the phrase often termed as a biomarker. What are the biomarkers that separate out those two groups of patients in order to frankly do the diagnosis without having to do an aspirin challenge or predicting for patients, hey, don't take aspirin, it might not be safe for you. We just aren't close enough to truly understanding the mechanism of the disease, which is why we have so much behind the scenes work happening right now at the lab bench to try to understand enough more that we can then develop that test better. So my answer is yes, there's research being done, fingers crossed that we actually get there eventually. Does living at altitude affect AERD symptoms? As far as I can tell, no. So by definition, if you live in the Boston area, you don't live at altitude, but we have lots of our patients who have come from elsewhere or moved back. I'll every now and then actually have a patient tell me that when they go hiking at altitude, they actually magically feel better, as though they're clearer. I've had more than one patient tell me that, so there might be something to it, but I'm not exactly sure what. But overall, we've not had patients living in high altitude levels had any better or worse outcomes than people living at sea level. So in terms of general things, do AERD patients need to avoid topical NSAIDs? So it probably depends on your level of sensitivity. The real question there is, are you absorbing enough of the NSAID into your skin that you get a systemic level of it enough to cause a reaction? We do know that this can happen with eye drops. There's some NSAID eye drops that absolutely can cause a reaction, actually can even cause a systemic reaction. Some patients do fine with topical NSAIDs, many do not. So in general, if possible, we try to have patients avoid these. If you really need it for some other treatment, we can do a challenge in the office and see how it goes. So the question about, is it possible to have AERD without having asthma? We estimate that about 5% of our patients have AERD without asthma, so that is possible. It's not as common. Will some patients then develop asthma if they have the other two symptoms but not yet asthma? It is possible, it happens occasionally, but usually if you're going to have the asthma, it starts out earlier along with the polyp disease as well. Does AERD usually get better or worse with age? There's no clear-cut answer to this. In general, our patients have shown that the first 5 or 10 years of the disease are the worst, and it tends to either plateau or become ever so slightly more mild for the rest of their life. It is not, however, clear to me if that's because the first 5 or 10 years is when we're struggling to get the diagnosis, to get the right specialist, to get the right medications, to get kind of you on the right set of treatments that are going to work for you. And we finally kind of hit that eventually, and you can coast a little bit better after that. Or if the disease itself actually decreases in severity over time. We very rarely see there being an uptick in severity after having already had it for 5 or 10 years. So is there any research going on to determine what causes AERD? As in the question about the test to try to diagnose it, absolutely yes, in multiple labs all over the country and all over the world, actually, ours for sure. And it's hard. It's hard to do this because there's so little that we know, that there are so many holes to fill with questions that we are not yet there yet. Which brings me to the unfortunate answer that I'm going to give to the final bullet point. Do I see a cure on the horizon? Not in the next 5 years, because I haven't been able to answer yes to we know what causes it or how to diagnose it better yet. So I think we still have a lot of struggles before I would be able to honestly tell you I think we're close to truly curing it. It doesn't mean it's not out there. It just means that I don't think there's a medication that I know of or treatment that I know of that's in the works right now that I think is going to really come to fruition in the next 5 years. I think we have some really good candidates that are being worked on, but it takes a long time to figure out whether or not they're the magic cure or not. But that for sure is our goal now and probably forever. So are there any other health conditions related to AERD? So we had a whole list of things people are asking about here. So I'll take them a little bit separately. Celiac disease, no. I do not know of any association between celiac disease and AERD. I have patients with AERD and celiac. I have patients with AERD and no celiac, but the rate of celiac seems to be about the same as in the general population. And I would say the same is true for Crohn's disease. The hereditary alpha-tryptosemia is a sort of advanced question that we have only just recently begun to look into. The answer is we don't know yet about alpha-tryptosemia, so I can't give you a true answer then. If you look at all patients with AERD, their tryptase level, tryptase is a chemical released by mast cells that you can measure in the blood, on average tends to be a little bit higher than the average population. It isn't clear if there's any suggestion that's truly from alpha-tryptosemia or just that patients with AERD have a little bit more activation of mast cells. So the last thing in that list about mast cell activation, so the phrase mast cell activation syndrome or mast cell activation disease is its own entity that is totally separate from AERD. The problem with that term is that a lot of AERD is actually driven by mast cells, including, we think, a large portion of the aspirin and NSAID-induced reactions. That's separate from being a mast activation disorder. It just means that I think your mast cells are causing you a lot of troubles, but that's true of almost every allergic disorder. So, I mean, peanut allergy is a mast cell activation disorder to some extent, because when you eat peanuts, your mast cells become activated and cause anaphylaxis. So mast cells are at the crux of a lot of what we do in allergy and immunology. And yes, I blame them for a lot of the symptoms of AERD, but it's separate from describing it as a mast cell activation disorder. And Ehlers-Danlos syndrome, as far as I know, also has no association with AERD at all. I have 2 patients in our group who have Ehlers-Danlos, but again, that's about what we'd expect in the general population. So I don't think we know of a real association there. So kind of going through some of this, other things, are patients at risk from developing other diseases? As far as we know, no. I'm going to hop down as a caveat to that, to the third thing on the bullet point there, that how sure am I that AERD isn't an autoimmune disorder? It's sort of a double negative. The answer is I'm actually not that sure that AERD isn't an autoimmune disorder. There is a large piece of me that thinks, this is a gut feeling, which is not a great way to do science, but there is a piece of me that thinks that AERD actually is a type of autoimmune disorder. So in that sense, does that then set you up for developing other autoimmune disorders? We started looking into this when I got worried that maybe I wasn't being as careful about looking for other autoimmune diseases in my patients. And the answer is probably no, actually. We looked pretty hard and did not see an increased rate of other autoimmune diseases in our AERD patients. So as far as we can tell, no, I don't think it sets you up for other autoimmune diseases. Now, why does AERD cause fatigue, and what can be done about this? That is a multi-pronged answer because there are multiple reasons. I can list a couple. One of maybe the least satisfying, but probably most common, is that uncontrolled asthma and or uncontrolled sinus disease, especially if your polyps and congestion is so severe you can't breathe through your nose, right? So if you're kind of breathing through your mouth all the time, is at really high risk for terrible sleep disturbances. And whether or not you're aware that you're not sleeping well, or your spouse might be aware that you're not sleeping well, a huge portion of our patients report really poor quality of sleep. Sometimes it's as obvious as you're waking up at 2 o'clock in the morning because your asthma is exacerbated and you need to use an albuterol nebulizer. Sometimes it's more subtle. So a component, I think, of the daytime fatigue is actually poor sleep. So then we need to drive it. Why is it respiratorily, nasally, patients aren't sleeping well? There might be a more complex answer to this that gets a little bit fancy. There are a couple of chemicals, for lack of a better word, that are released by cells in AERD, in the polyps and in the lungs, that are suggested to actually in and of themselves be a little bit sleepifying. Soporific is the term. So one, prostaglandin D2, called PGD2, there's suggestions that it in and of itself can make you sleepy. So it might actually be that a component of the inflammation that you have contributes to you actually feeling fatigued, regardless of how well you sleep. Then, of course, what can we do about it? I don't have a good answer for that one either. If we're concerned about that, there are a couple of medications that can help to dampen down mast cells in AERD, one called Xyluton or Zyflo that blocks leukotriene production, might overall kind of dampen down mast cells, but there hasn't been a good study that really directly drove at how to try to treat the fatigue in this disease. And I think it's something that we as researchers should start being more careful about asking about and following. Can AERD cause inflammation of the muscles or nerves in the body as well? I'm going to sort of give a soft no on that one. In the sense of true like muscle or nerve inflammation, no, not systemically. We do have patients who get kind of aches and pains, almost like an arthritis kind of feeling. And that can sometimes come along with that funky rash I was describing on the hands and the ankles. We think that arthritis, stiffness, and rash is driven by overproduction of those chemicals called leukotrienes, in which case that medication, Xyluton or Zyflo, might be helpful as a trial for that, but it isn't really inflammation in the muscles or nerves. And how sure am I that AERD can't be inherited or doesn't run in families? This one I'm pretty sure about, in the sense that in 1,400 patients, 1,500 patients we follow, I have one mother-son pair, and I have one brother-sister pair. But for the other 1,398 patients, there's no other patients in their family who have AERD. Nasal polyposis, or chronic rhinosinusitis with nasal polyps, and severe asthma does have some heritability. So most of our patients have no family history of asthma or nasal polyps, but there are a higher percentage of patients who have a family member who have nasal polyps, but it isn't clear that that's a direct correlation to the AERD. We also actually in our cohort have several what are called identical twins, so genetically identical people, and only one of the twin has AERD. So in that sense, we know it isn't truly inherited within the genetic makeup of the family. So now we have a sort of a case scenario here. So I was diagnosed at 23, and so far this person's been able to comfortably manage their AERD symptoms with some medications and some rinses. I suspect we need sinus rinses. And this person has had one surgery in the last 3 years. So this person, it sounds like it's sort of looking through some Facebook support groups and realizing, you know, I actually feel okay with where I am. I'm seeing people have surgeries every year, bad reactions. Mine seems a little bit better managed. So I would say that is great. That is a great outcome for you. In general, your disease kind of is what it is. So if you've had, the patient was diagnosed at 23, I don't know how old they are now, but if they've only had one surgery in the last 3 years and feel like they're managing with just some rinses and medications, that's a pretty good outcome. My suspicion is that is about how you're going to coast through the disease for the next few decades. I don't think it's necessarily going to go away, but I would not necessarily expect it to suddenly get worse. Usually it kind of is what it is. So in that case, I think you're one of the lucky ones who's unlucky enough to have this disorder, but lucky enough to have a component of it that seems relatively manageable. We went through the AERD hereditary piece, but this person is really sort of asking about their kids, I think, a little bit as well. So in general, I am very clear with my patients, especially when they're early diagnosed. If you have already, or if you go on to have biologic children, we do not think that your children have any increased risk of developing AERD as anyone else has. So this person sort of had their children avoid aspirin ibuprofen throughout their lives, and now they like want to know what they should do. So if you have AERD and your children have no other signs of AERD, they do not, for example, have nasal polyps, I don't think there's any reason to have them avoid taking aspirin ibuprofen. I think they can just go ahead and take aspirin ibuprofen. I don't even think that they would need to do a formal challenge because I don't think that their risk of reacting is higher than the general population. But the next question is a little bit more complicated. So AERD doesn't always present till, adulthood, 30-ish. Would it be a good idea to do a challenge now or later? Because this person, I guess 24-year-old, kind of started getting some allergic rhinitis in college, and it's frequently stuffy. So if this now 24-year-old really just has allergic rhinitis, meaning I get runny noses when I'm around dogs or cats or dust mites or pollens, and that's the only symptom I have, that to me does not increase risk of AERD. So I still think, go ahead, take aspirin ibuprofen. The other thing to keep in mind, because I get asked this a lot, you did not cause your disease by taking a lot of aspirin or taking a lot of ibuprofen. You did not cause your disease. In other words, if at this point in your life you have AERD, you would still have AERD even if you've never taken an aspirin or an ibuprofen in your entire life. You would just have the asthma component and the nasal polyp component, and we may not know you had AERD because we hadn't seen those classic reactions, but the disease exists at baseline chronically, even without any aspirin or any ibuprofen ever having been taken. All right, so now moving on to the concept of aspirin desensitization. And this is a tough one because this is a pretty complex and a little strange procedure that we do that is very hard to explain even to other physicians and certainly to patients. So how safe is taking aspirin long term? In general, we think it's actually very safe. So we get to piggyback off of cardiology literature that's been putting patients on aspirin for 100 years, since aspirin was created in the late 1800s, early 1900s. And we think it's really quite safe. So those cardiology patients tended to use lower doses than we tend to use for aspirin desensitization or for aspirin treatment after desensitization. But in the mid-1900s, actually very high doses of aspirin were used for a lot of rheumatologic diseases before we got better anti-inflammatories and more advanced medications for some of those rheumatologic diseases. So again, we can piggyback off of some of that older literature that shows that even taking very high doses is quite safe. So in general, the safety things we worry about in aspirin, long-term or short-term, are slightly increased bleeding risk. It's not an incredibly high bleeding risk, but it is more than zero. And gastritis or stomach pain and stomach bleeding, that does not necessarily worsen with time. So it's not really a long-term effect. It kind of either happens or it doesn't. And that one is a little bit dose dependent. So all of our patients at any point they're on aspirin will always have a slightly increased risk of gastritis than anyone who isn't on aspirin. But it isn't a question of how long you're on it. It's just, it increases the chances of it happening overall. So how can persistent hives after aspirin desensitization be treated? So I'm going to interpret this question to mean that there are patients with AERD who develop a funky, very, very itchy rash. Again, I don't refer to it as hives. I think it's a little bit different, but it's itchy and it's red and it's either slightly flat dots or slightly bumpy. It looks like hives. And that can worsen during the aspirin reactions and it can continue after aspirin. This is tricky. And I think many of us in the fields of AERD who do these aspirin procedures have adjusted our practices a bit. For the patients for whom this happens, usually my goal is to then bring them down way, way low on the aspirin dose and be extraordinarily slow and gentle. So instead of trying to get the aspirin desensitization done in a day or two, we give it weeks or even months. So I will have patients on a half a baby aspirin for 2 weeks, one baby aspirin for 2 weeks, and go very, very slowly to see if we can get underneath it and continue the tolerance while having the hives go away. Every now and then that doesn't work very well. We can do a course of prednisone to try to knock them away and see if they go away. And actually this kind of rash tends to be extraordinarily responsive to a medication called xyluton that we already talked about, and also seems, we think so far, to be responsive to the newer biologic called Dupixent or dupilumab. We've had many patients who reported this kind of rash that went away on Dupixent. Can I take NSAIDs, sort of other NSAIDs, once I'm desensitized to aspirin? And if so, is it safe to take both an ibuprofen, for example, and aspirin daily? The answer should be yes to both of those questions. In general, the rule is that as long as you're on at least 325 milligrams of aspirin a day, so 1 adult dose per day, you should be cross-desensitized. So you can now tolerate ibuprofen and naproxen on top of it. And so if you get a migraine or menstrual cramps or knee pain, you can take ibuprofen as well. If so, is it safe to take both? The answer is probably yes. Usually if you're on the highest dose we usually go to, which is 2 adult aspirins in the morning and 2 at night, so 650 twice a day or 1300, you usually have already kind of covered the whole pathway of what NSAIDs are going to do to your inflammation. And additional ibuprofen on top of that may not do much. You've sort of done it all. But except for increasing the rates of gastritis, the likelihood of hurting your stomach, it is considered safe to do both. For patients who are a little bit more likely to get the queasy stomach or the gastritis, we recommend for everyone that you only take your aspirin and ibuprofen on a full stomach. And for some of those patients, you might want to, before you take the aspirin, take a Prilosec or a medication that's referred to as a PPI, sort of an anti-acid medication to help decrease gastritis. So does the effect of aspirin change over time, or will it be equally effective forever? So I don't know that the efficacy necessarily wanes. I sort of see the high-dose daily aspirin as a major tool on the battlefield. And I'll often warn patients, I don't know how long this is going to hold back those polyps. So if we do the, and in reference to the next question of which patients should consider aspirin desensitization, if we do the aspirin desensitization at the times that we hope to, that we want to, it's usually a patient who has had their polyps recently removed, so that you're within 2 weeks to 2 or 3 months after surgery, you're feeling good, your sinuses are open, you can still smell after surgery, there's no polyps there. And then we go in with the aspirin desensitization and start daily aspirin to help prevent those polyps from coming back. And then I follow you every 3 to 6 to maybe 12 months until either you keep seeing me once a year and telling me that you feel great, or until any inflammation and polyps starts to come back. And I usually will warn patients that we're fighting the battle with the aspirin. I don't know how long we're going to be able to hold off those polyps. Sometimes it's 6 months, sometimes it's 2 years, sometimes it's 12 years. And for each person, it's a little bit different. And unfortunately, there's no way to predict sort of what the best way to do that is. Biologics, right? So this is a topic that didn't even exist for us to talk about a couple of years ago. All right, so I see Xolair on here, Dupixent on here a lot. I'll try to get to as much of this as I can. How do you know which biologic medication is right? So that is a very case-specific answer, and I don't think it's something I can sort of give a general answer to 100 people that would be true for all 100 people. The answer is it depends. In general, we are finding that for most patients with AERD, where we want to treat both their nasal polyps and their asthma, because some of the biologics can do both, Dupixent tends to be the most efficacious compared to all the other available biologics. So then that leads into the next question is it becoming the gold standard as opposed to surgery followed by desensitization? And or can it be used in place of surgery before desensitization to remove the polyps? The answer is, I don't know yet. So Dupixent is new. We've only had it for a few years. I cannot tell you the effects of Dupixent for a decade of Dupixent, of shots every other week. We expect it's going to be okay, but we don't know for sure. And so if there's something else that we can do, we've been doing for 30 years that we know will work, we tend to do that. The other thing is that there is a huge cost issue. And so for a lot of our patients, or just for the healthcare in general, many of these biologics cost around $30,000 a year. That's incredibly expensive. So if a single surgery, really well done, followed by aspirin desensitization, will get you 10 amazing years of health without having to do injections every other week into your leg and travel with syringes and get new health insurance each time you get a new job, we try for that. So I would say for most new patients we're seeing, our standard of care recommendation is still one really good surgery followed by aspirin desensitization, unless there's some kind of contraindication to one of those two things, or unless you're coming to me having already tried those 5 things before and you're sort of at the end of your rope, and then we'll go straight to Dupixent. Dupixent can be used to kind of shrink back the polyps prior to aspirin desensitization, yes, and we are starting to do that occasionally for a couple of patients who really couldn't go to surgery for a number of reasons. And for those patients, it's not even clear that you necessarily need to be on aspirin every day to prevent the polyps from coming back. But we do actually have a lot of patients who notice they do best on Dupixent and aspirin together rather than one or the other, which kind of answers the question in the yellow box. If you feel great on Dupixent, should you maintain aspirin desensitization? Yeah, that depends. We're still learning. Our recommendation I think, for most of our patients who are in that scenario. So they were on aspirin, they were maybe doing okay, but not good enough. We got them with Dupixent, they feel great. Should they just stop the aspirin? We've had a few patients who just stopped the aspirin because they felt great, and then 2 months later realized actually the aspirin was helping them. So then we need to repeat desensitization. Our current recommendation, I would love to get patients on fewer medications. If aspirin's not helping you, let's get rid of it. We usually will bring patients down to a pretty low dose, maybe 1 baby aspirin a day, maybe 2, and stay there for a month or 2, because if you feel totally great on that baby dose, that dose isn't enough to keep your polyps from coming back, suggesting the aspirin actually isn't doing anything for your disease, and you can stop it if you want to. On the other hand, if you come down to just 81 milligrams and you start to worsen and flare, we realize the aspirin probably was doing something for you, and we can increase it back up slowly without having to come in and repeat the entire desensitization. So, is joint pain a Dupixent side effect, and how common is it? The answer is probably not that common, but not 0. So we are just actually right now in our group, it's actually being run by Dr. Kathleen Bouquet, putting together a case series of patients we've seen. It's around 5 or 6 patients with AERD, prescribed Dupixent, who got pretty clear joint pain of one form or another, either after the first couple of shots or a little later into it. And the evaluation that we did, workup we did, et cetera. And at the end of the day, we're going to try to publish this so others can see it as well. It ends up being only a couple of % of patients. It's still very rare. And nearly all of those patients were actually able to continue their Dupixent without stopping it. And that joint pain went away. That's the good news. The bad news is that despite a reasonable amount of effort of evaluation, we still haven't figured out quite what that joint pain was. We had some rheumatologic workup and some blood workup, and I cannot tell you biologically or immunologically what was going on, and that frustrates me. So then 2 questions about Xolair. Xolair was recently approved for polyps. Is it as effective as Dupixent? No. Overall, if you look at the trials, the big trials the companies did, overall the answer for everyone with polyps, Xolair was not as effective, and it certainly was not as effective as Dupixent as bringing back your sense of smell. If you separate out just the AERD patients, Dupixent is still better than Xolair. Xolair has some effect in most patients, but Dupixent in general tends to be better. Xolair has a black box warning about anaphylaxis. At the risk of being a little bit facetious, I don't think that's very important. I'm more than happy for my patients to get their Xolair at home if they're allowed to. For our asthma patients, we were allowed to for COVID. Xolair-induced anaphylaxis is exceedingly rare, and I personally don't think that patients should be required to get it in the clinic. I'm okay with them getting it at home, but not all insurance agrees with me, and the FDA doesn't always agree with me, but the data doesn't really suggest that we should be super worried about it. And Dupixent-induced anaphylaxis is almost unheard of. There's always a case report here and there, but in general, I feel pretty safe about Dupixent being given at home as well. All right, so we've gotten through what had been sent in before. This leaves us nearly 10 minutes left in our hour. And Sally, I'm more than happy to try to tackle new things that have come in.
Well, you are being such a great sport answering all these questions, but we have like maybe 75 more. We'll get to what we can.
We can't do that all in 7 minutes.
Well, yeah, but we'll get to what we can. A lot of the questions you've answered parts of them at least. Okay. So I feel good about that. Okay, our first question is going to be, have there been studies on how hormones can affect AERD? Some say their symptoms get worse depending on their hormone fluctuations.
Good, that is a great question. The answer is not yet formally, but they are in the works. And this is one of the reasons I like doing these things, and I like seeing patients and answering questions, because I have a rule. This is going to be a tangent. I'll get back to this. I have a rule. It's my rule of 3s. The first time a patient tells me something that I think is totally wackadoo and couldn't possibly be related, I sort of smile and nod and I write it down and I don't do it. The second time I hear a patient tell me the same wackadoo thing, I remember the first wackadoo thing and I think, huh, that's funny. Those both sound a little strange. Nothing. The third time I have a patient tell me the same symptom, I now have to go back and say, okay, I have to remove the insulting label of wackadoo. My patients know a lot more about their disease than I do. all three of these patients are clearly right. I need to call them all back and get more details and try to investigate it. That's how we figured out about alcohol reactions. That's how we figured out the rashes. There's a lot we figured out just by listening to our patients. Also true for the hormone issue. So a woman, a doctor who worked with me for a long time, actually up here at the Brigham and is now at Vanderbilt, Dr. Katie Cahill, may have treated some of you, is actually working hard to try to understand the role of hormones as a general term, both in terms of sex-specific hormones, right? So we know that AERD is more common in women, tends to develop a little earlier in women, tends to be a little bit more severe in women. Why is that? Is there a hormonal component to it? But it doesn't go away postmenopausally in women. So it isn't just purely caused by like quote unquote women's hormones. We absolutely have patients who kind of rotate their severity with their menstrual cycles. That's been known for other kinds of asthma as well, so that's being looked into. And the truth is that when we use the phrase hormones, we both in the lay public, but also often in the medical terminology, are kind of referring to women's hormones, which is kind of like not fair to men because there's a lot of hormonal changes in men as well that aren't being appropriately investigated. So that the answer is yes, it's being explored, absolutely. There isn't any data yet that I could talk about that makes sense yet, but we are absolutely looking into it.
I have a follow-up question that says, I saw a naturopath who said menopause affects lung health in general. Is this true? And would taking any extra vitamins and minerals such as magnesium be helpful?
So I don't think that's specifically related to AERD, but there are a ton of changes that happen after menopause for women. They have to do with cardiac health, cardiovascular health, and pulmonary health. So yes, overall, the answer is yes, that is true. I don't think that any additional vitamin kind of supplementation would necessarily have anything to do with fixing that, unless you're known to have a specific vitamin deficiency. But in general, as long as you're eating a pretty healthy diet throughout your older years as well, it's pretty hard to develop a true vitamin deficiency that would require replacement. So I would not guess that things like magnesium replacement would make much of a difference.
Okay, great. So this next one, this is a rather it explains their situation. It's kind of, I find it interesting to say it out loud, but I'm going to do it anyways. The question is, I've been diagnosed with AERD in 2018 and have blown chunks of yeast out of my nose. Yep. Does Candida yeast overgrowth have anything to do with AERD as well? Is this normal?
Okay. So the phrase blown chunks out of my nose is actually a pretty common phrase I hear from my patients. So that's classic. For sure it's not normal, but why? I don't think that yeast or overgrowth is directly related to the mechanism of AERD immunologically. Like I don't think it is caused by AERD necessarily. However, there are two reasons that I think that our patients with AERD are at much higher risk of yeast overgrowth. One is intranasal steroids and pulmonary steroids and oral steroids, right? So steroids, especially high dose oral steroids, but it's even been seen with intranasal and inhaled steroids, can locally decrease the immune system enough that yeast that was there normally can overgrow. So that's unfortunately a time we need to dial way back on steroids and really try to get rid of the yeast as much as possible with local rinses or with pills, depending on the severity. The other reason is that many patients with AERD, I think, are probably misdiagnosed along the way with a lot of bacterial sinus infections. The first few times you get kind of pain and discomfort and runniness out of your nose and chunks out of your nose, the common go-to is, oh, I have a bacterial sinus infection. And many of my patients have come just being given lots of antibiotics because nobody knew what to do with them otherwise. And lots of antibiotics absolutely set you up for also then being able to get yeast overgrowth, because the antibiotics that they're trying to kill bacteria in your nose will also kill bacteria all over your gut, and you end up really kind of messing up that equilibrium of the yeast and bacterial forms that we want to have in our gut. So there is definitely something that we see in patients with AERD.
Okay, we've just got time for a few more. I wish we had hours left, but that would probably be kind of brutal for you, Dr. Laidlaw. So somebody says, I have had 6 sinus surgeries with the removal of the ethmoid processes. Along with sinus irrigation, what else will help reduce polyp formation?
Yeah, so sinus irrigation with high-dose steroids. So sinus irrigation just with saline packets will make you feel better, and it's probably you should do it, but it won't decrease the inflammation. So you want to make sure that you're definitely sinus irrigating with high-dose steroids. I have patients use budesonide, liquid budesonide or Pulmicort as much as possible, number one. Number two could be aspirin desensitization. If this patient hasn't yet attempted an aspirin desensitization and daily aspirin therapy, that can help prevent them from going back. And number three will be Dupixent. It's my sort of in that order of events.
Okay. Well, we have a couple of comments. One of them is, "We love you, Dr. Laidlaw." And and another one, I had it pulled up and then I went to look for something else. But basically someone wrote in and said, you know, years ago, I was told to take high amounts of NSAIDs for a bad menstrual situation. And I always had worried that I had triggered my own AERD. So she was incredibly thankful that you were so specific tonight to say that
not
you did not make this happen to yourself.
No.
But I think that kind of reassurance is just everything sometimes.
Good.
And then the last comment that I'd like to read to you before we call it this a night is someone else wrote and said, "Just sending love and gratitude to Dr. Laidlaw and your team from the Samter Society." So everybody really appreciates the work that you're doing for and with all of us. Good. So if you could just move it one more, go ahead.
No, this is a really tough disease to have. It is a mystery to patients. It's a mystery to researchers. It's a mystery to doctors. And you never want to be the patient that has a mysterious diagnosis. It's super frustrating. And we are, all of us in the field are really working hard to make it better for you.
Well, if you could move it one slide ahead, I would like to say thank you so much for tonight, Dr. Laidlaw. We totally appreciate you being here, listening, and for all of those answers. I want to remind people that Dr. Laidlaw gave answers pursuant to what is reasonable for today, and that you know, everything changes pretty quickly in the medical field. So please just keep in mind that you know, talking to your doctor and finding out what's best for you is always a really sound practice. But we'd like to thank Dr. Laidlaw for helping us mark AERD Awareness Day 2021. Thank you all for joining us this evening. And Allergy and Asthma Network thanks you as well. So take care and hope you have a healthy year.
Thank you, everyone.